Dear students, this is Dr. Omid, and in this video I'm going to talk about the first part of the gastrointestinal tract. Hopefully this video it will be useful for your studies. Gastrointestinal tract is started from oral cavity, which is divided as oral vestibule and oral cavity proper that we are going to discuss. Then the pharynx, that it has three parts: the nasopharynx, oropharynx, and laryngopharynx. Then it continues at the level of C6 as the esophagus, which has the cervical part. Then it enters to the thorax as a thoracic part, the longest, and then it's perforating the diaphragm, and the shortest part is the abdominal part, that it's finishing at the level of the stomach. To the stomach, to this opening, which is called cardiac ostium. Here is the stomach. Then the stomach, it's from the stomach it continues the gastrointestinal tract to the small intestine, which consists of three parts. The first part is here, which is called duodenum. Then it's followed by jejunum, and jejunum is followed by ileum, and finally ileum it open to the large intestine. The first part of the large intestine is called cecum. And at the cecal region you have the appendix, vermiformis appendix, and the cecum cranially continue as a ascending colon, and finishing at the right colic flexure and continue as a transverse colon, which is finishing at the left colic flexure, and it continue downward as a descending colon. And the descending colon, it's followed by this S-shaped colon, which is called sigmoid colon, which is continue to the rectum, which is generally it's composed of the superior part, which is called ampulla, and the inferior part, which is called anal canal, and finally the anus. So this is the general part of the gastrointestinal tract. Of course, to this pathway you have to add the glands of the gastrointestinal tract, which is the very important part is liver, and also gallbladder. So here there are the pathway of the bile to the duodenum, to the small intestine, and here is the location of the pancreas, is the another gland of the digestive system, which is exocrine, is producing the pancreatic juice, and also is endocrine gland, which is producing the hormone insulin and glucagon, that we are going to discuss all of them in details. General structure of the digestive system. The digestive system, most of the part of the digestive system, generally they have four layers. From inner side to outer side, the most inner layer is tunica mucosa, or mucosal layer. Mucosal layer is here the most inner part, and it's covered by the epithelium or epitel. This epitel is varied in different parts of the digestive system. Most of the part they have squamous epitel or cylindrical epitel, that in each part we are going to discuss. So here is the epitel, and after the epitel you have the connective tissue, which is called the proper lamina, or the lamina propria mucosa. The proper lamina is here, is the whitish part, here the connective tissue, which is immediately under the mucous membrane is located. This is called the lamina propria mucosa, and most of the time after that you can find a narrow muscular layer that here is the lamina muscularis mucosa, is the muscular layer of the mucous membrane. Here is the short part. This mucous layer that you can see it here, it's usually in the digestive system. They are making the folds or pellica, or they are making, especially in small intestine, the villi for the resorption of the wanted material, or they are making some papilla here in this mucosal layer. Then in the mucosal layer also you can find some lymphatic tissue, which are called lymphatic follicles. Lymphatic follicles, there are two types usually in digestive system. The most of the part of the digestive system, they have solitary lymphatic follicles, and in as you see here, and in some part of the digestive system also we have aggregatory lymphatic follicles, for example in ileum. After this mucosal layer, the next layer that you can see here, it's the connective tissue. It's called the submucosal layer, or tunica submucosa here. In the tunica submucosa, which is composed of the connective tissue, you can see the nerve plexus. This nerve plexus is called submucosal nerve plexus, or they call it Meissner nervus plexus, and it's inside the second layer, the tunica submucosa. After the tunica submucosa, you have the muscular layer, or tunica muscularis, or the muscular layer. This muscular layer, usually in most of the part of the digestive system, we have two layers. The inner layer, that as you see, is usually the circular muscles that are located, and outer part we have the longitudinal muscles. Between the circular, inner circular and outer longitudinal layer, again you have another nerve plexus, which is called the muscular plexus, nervus plexus, or Auerbach nervus plexus, which is between the circular and outer longitudinal layer is located. Of course, there are some exceptions in some part of the digestive system. For example, stomach, it doesn't have this typical two layer. It has additional third layer, the deepest layer, which is making the oblique fiber, and they are passing according to its name obliquely. So this is an exception, but most of the part of the digestive system is composed of this inner circular and outer longitudinal, and between these two there are the Auerbach nervus plexus, or the muscular nervus plexus. And finally, this green part that you can see, it's the most outer layer, which is the tunica adventitia, is the adventitia, which is covered most of the part of the digestive system. Of course, some part of the digestive system that is covered by the peritoneum, which is the serous layer. Instead of tunica adventitia, then the name is changing as a tunica serosa. So because the peritoneum is formed by, or is made by the serous layer. So in the part that they are not covered by the peritoneum is called tunica adventitia, and the part that they are covered by the peritoneum is called tunica serosa. Those are the general structures. So as you see here, there are some glands that they are penetrating to the submucosal layer. They have in the digestive system. We have different type of the glands with the different type of the secretion, and also you can see some vessels in the place of the tunica, submucosal, layer. So those are the most important part about the basic structure of digestive system. First part of the gastrointestinal tract is oral cavity. This is the oral cavity. Generally, oral cavity is bordered anteriorly by the upper lip and lower lip. Superiorly is bordered by the palate, which is composed of the hard palate and partly soft palate. Laterally, which is not seen here, is bordered by the cheek or buccal region. Inferiorly is bordered by the floor of the oral cavity, which is the most important muscle of the floor of the oral cavity. Is this muscle? It's the mylohyoid muscle. Above the mylohyoid muscle, you can see the mental spine. Here is the geniohyoid muscle, and here is the genioglossus muscle, which is the muscles of the tongue we are going to discuss. So posteriorly, as you see, we don't have the border. It's open, the oral cavity. It's open to the place which is called oropharynx. It's open to the pharynx. This part of the pharynx, which is communicating to the oral cavity, is called oropharynx. And this opening is called isthmus of Faucium. This is the posterior relation of the oral cavity with the oropharynx or pharyngeal region. Oral cavity, generally we divide them to two parts, like a nasal cavity that we divide them to the nasal vestibule and the nasal cavity proper. Oral cavity also is divided to the oral vestibule and oral cavity proper. Oral vestibule is this space. Anteriorly is bordered by the superior lip and inferior lip. Posteriorly, it's bordered by the alveolar process of the maxilla and alveolar process of the mandible with the teeth, the dental arch. And laterally, it's bordered by the cheek or buccal region. So superiorly, this oral vestibule in anterior region is finished with the superior fornix and vestibular fornix, and inferiorly by the inferior vestibular fornix. The oral cavity proper is exactly behind the alveolar process, and teeth is this place, and the main organ of the oral cavity proper is tongue. That is very important, and we are going to discuss separately. The communication between the oral vestibule and oral cavity proper is very important. One communication is the space between the teeth. It's called interdental space or interdental fissure, sometimes they call it. So it can be communicated from the oral vestibule to the oral cavity proper, and also behind the last molar, as we mentioned it in the skull, we have the triangular space, which is called retromolar space, and through this retromolar space behind the last molar, the oral vestibule is communicating with the oral cavity proper. Clinically is important in the case of the fracture of the jaw. If you connect the upper jaw with the lower jaw and the patient cannot open the mouth to take some food, of course the fluid food or soft food, either by the space between the teeth, the food it can goes from the oral vestibule to the oral cavity proper, or you can via this retromolar space, the patient can eat. So this is the general borders and general information about the oral cavity proper, and the division of the oral cavity to the oral vestibule and oral cavity proper. Here you have the sagittal section through the oral cavity and also nasal cavity. For your orientation, here is the upper lip, and the lower lip. Here is the hard palate. As you see, hard palate is formed by the premaxilla or incisive bone, the palatine process of the maxilla, and horizontal plate of the palatine bone. Continuation of dorsal continuation of the hard palate is this soft palate, which is making the posterior 1/3 of the palate. And down here it's the tongue that you can see. The space between the bone and alveolar process, here is missing teeth, here is the oral vestibule, and here is the oral cavity proper. You can see the extraglussal muscle here, the genioglossus, which is originated from the superior mental spine, and it goes to the aponeurosis of the tongue, which is immediately under the mucous membrane and epitel and papilla of the tongue, and separating this aponeurosis, the mucous membrane, from the muscular compartment. So this is the genioglossus. This is the bulky and the biggest and largest muscles of the tongue, which is very strong and is protruding the tongue. Under that is this muscle, which is called the geniohyoid muscle, which is starting from or originated from the inferior mental spine and is attaching to the hyoid bone. And finally, under that is the mylohyoid muscle. The mylohyoid muscle, as we mentioned, is the important muscle which is separating the oral cavity from the neck region. So under the mylohyoid, whatever you can see here is the neck region that we are going to discuss in topographical anatomy. And here the soft tissue or the soft palate, it's continue from the posterior nasal spine of the palatine bone, and it's hanging as a ovula in the center, and this is by the contraction is closing the entrance to the nasopharynx. Here is the nasopharynx. As you see, here is the opening of the eustachian tube or auditory tube. This is called pharyngeal opening of the eustachian tube inside the nasopharynx. This communication, it's the Juane, which is connecting the nasal cavity with the nasopharynx. This opening is called Juane, and here is the nasal cavity proper, and you can see very nice the inferior nasal concha. Here is the middle nasal concha, and here is the superior nasal concha. The spaces between them, here is the inferior nasal meatus, is the place for opening of the nasolacrimal duct, and here is the middle nasal meatus between the middle nasal concha and inferior nasal concha. Here is the place for the opening of the maxillary sinus at the region of the semilunar hiatus, and also the opening of the frontal sinus here, and anterior and middle ethmoidal air cells. And finally, here in these spaces between the middle nasal concha and the roof of the nasal cavity, here is the space which is called superior nasal meatus, which is the place for opening of the posterior ethmoidal air cells, and also the sphenoidal sinus, which is open at the level of the sphenoethmoidal recesses. And here is the lumen nasi, which is separating the nasal vestibule from the nasal cavity proper. that you can see is the curved line, which is called Lehman nasi, and here is in the vestibule, vestibule of the nasal vestibule. You can find some hairs that they are called vibrissae. And here there is a cribriform plate of the ethmoidal bone, which is the place of the roof of the nasal cavity, and it's the place for the passage of the fila olfactoria or cranial nerve number 1, olfactory nerve, plus the anterior meningeal artery pass through one of these openings. So this is just for your orientation to recognize. And here there are the muscles that it scenes, and here if I turn it, you can see the papilla of the dorsum of the tongue here, and we are going to the root of the tongue, which is connecting with the epiglottis via the folds that I already mentioned. So as we mentioned, the lips, they are bordering the oral cavity anteriorly or ventrally. As you know, we have upper lip and lower lip that they are located in the frontal part of the face. The basic part of the lips, there is a muscle which is called orbicularis oris, and also other mimic muscles. The superior and inferior lip, they are meeting each other at this place, which is called angulus oris. The angulus oris, the angle of the oral cavity, or the angle of the rib, is called angulus oris. Then the free border between the upper lip and lower lip is this part, which is called the rima oris. Superior or upper lip, it's related to the nose, and laterally and cranially till the angle of the mouth, or the angulus oris, there is a sulcus which is called nasolabial sulcus, which is craniolaterally, it's bordering the labial region. Above the superior lip, there is a small depression which is called philtrum here, and it's continue upward to the nasal septum here. At the center of the upper lip, you can find the tubercle, which is called the labial tubercle, and is very well seen only in upper lip, and a small part in the lower lip, but mainly in upper lip. The border between the labial region with the chin or mental region is this sulcus, which is called the mentolabial sulcus, separating the mental region from the labial region. And as you see, the upper lip and lower lip, they have some part that it's more reddish. The border between this reddish part and the normal skin region of the lip is this border, which is called transitional zone. Transitional zone. This reddish part of the lip, it's because of the highly vascularized structure of this part below this papilla chorea. They have a very rich blood supply, and that's why it looks like a red and the reddish color you have. And another thing in this transitional zone and this red part of the lip, we don't have any hair follicles, you don't have any sweat glands, and you don't have any sebaceous glands. And the border between the normal, this reddish part, and the normal skin of the lip, that usually they have all this structure that I mentioned, is the transitional zone. The lip, the development of the upper lip It's sometimes it will be disturbed, and the disease is called cleft. And this cleft, either it can be in the lip alone, or it can be together with the jaw or maxilla, or it can be together with the lip and jaw and the palate. And that's why we have the three different cleft in the or lip cleft we have in the developmental disorders in children usually. So beginning of the digestive system, as you see, is the oral cavity, and the entrance of the oral cavity is anteriorly is bordered by the upper lip and lower lip. Upper lip and lower lip together, they are joining together in this part, which is called angulus oris, or oral angle. And the free border between them is the rima oris. The upper lip, it's separated from the other region by the nasolabial groove. Here is connecting from the nasal wing, and it going to the angulus oris. And also in the center we have some depression which is called philtrum, and in the upper lip here we have the tubercle. This is the border, the transitional place between the red part of the lip and the skin part of the lip that we already mentioned, the difference between them. This groove is the mentolabial groove, which is separating the lower lip from the mental region, and this is the border between them. If I open it, so you can see the entrance to the oral cavity, and the oral cavity we divide them to two parts. The part that my pincet is inside, it's between the lip, here is the lower lip, and the teeth, which is here, which are located inside the alveolar process of the mandible. This space that my pincet is inside is called oral vestibule. So this border dorsally is bordered by the cheek region here, and it's the small space, and it's called the oral vestibule for upper lip also. If I turn it and I look at it from the posterior view, you can see the dental arch here and the alveolar process, and whatever behind it means toward me. So this area is the space which is called oral cavity proper. And inside the oral cavity proper, as we mentioned, is the tongue. It's the main organ, and also superiorly is bordered by the hard palate. Here the nasal cavity that you can see the very nice the nasal septum, and here is the inferior nasal concha, and here is the middle nasal concha, and superior nasal concha is the smallest one. So back to the oral cavity proper here, you can see that it's the immediately posterior to the alveolar process and teeth, and in front of that here, very nice, you can see this space is the oral vestibule. Inside the oral vestibule is open, for example, the duct of the parotid gland in front of the or opposite to the upper second molar, and the other duct, it means submandibular and sublingual, it's open to the oral cavity proper, which are important. And the communication between the oral vestibule, it's important to the oral cavity proper during to the intermaxillary fixation of the upper jaw and the lower jaw. So those are the tongue and the septum, the lingual septum, and those are the fiber of the intrinsic muscles of the tongue that you can see. And between the muscles of the tongue, for example, here is the space which is called median intermuscular lingual space, which has and paralingual space, which are the place that the infection and exudation can spread toward to these spaces. And here you can see very nice the maxillary sinus, which is belong to the respiratory system. General structure of the teeth. Each tooth is composed of three main parts: the crown, neck of the teeth, or neck of the tooth, or cervical region, and root of the tooth, or radix. Inside the tooth there is a cavity which is called dental cavity, or which is composed of the dental pulp or pulp chamber, which is continue as a root canal, and it ended at the apical foramen. Apical foramen is the place that the vessels and nerves, they are passing inside and outside of the pulp and pulp chamber and root canal. The crown of the tooth is covered by this structure which is called enamel. Enamel is the hardest structure of the body, is approximately 1.5 millimeter. It has its thickness. It composed of 97% of an organic structure, and it's made by the cells which are called ameloblast. And this ameloblast, they are forming this enamel, which are formed as a shape of the prismata or prisma. Then the largest part of the or material of the tooth is this part, which is called dentine. Dentine is the color. It's approximately a little bit is toward the yellowish color. The enamel, it's the whitish color mostly, and is formed by the cells which is called odontoblast. These odontoblast, they are located usually near to the pulp chamber, and they have some extension and processes which is penetrating toward the dentine, and these processes and extension is toward the dentine, and they are covering the pulp chamber also. This dentine, they are composed of approximately 70% of anorganic material, and it's harder than the bone, the material. And also these nerves that they are going to the pulp chamber, they are penetrating toward the dentine, and that's why the dentine is sensitive. That if the caries is going to the dentine, the region, so you can feel the pain and sensitivity of the tooth. But enamel, it doesn't have any sensitive innervation, and but the vessels, it doesn't penetrate to the dentine. Then the next material is the cement, which is here. The cement is covering the root region and the neck region, and the material is the same and similar to the bone, and it's, as I mentioned, is just covering the root and the neck of the tooth. The place of the neck of the tooth, which is the place that the enamel and the cement, they are meeting each other, individually, in individual or in different people, it's different. So 60% of the population, they have that the cement is overlapping the enamel. So it's protecting the cervical region. In approximately 30%, the enamel and the cement, they are edge to edge finishing to each other. And the edge to edge, when the enamel cement is finishing, the enamel is starting. So that's why is in 30% of the population they have. And finally, in 10% of the population, in the cervical region or the neck region, the cement, it doesn't reach to the level of the enamel, and that's why they have the very sensitive neck or cervical region of the tooth, and when they are drinking some cold water or ice cream, they have pain, or they feel pain or sensitivity in this cervical region. So that's why, because the dentine is not covered by the enamel and is not covered also by cement. So that's why the dentine is exposed. Then the place that the root is inside the alveolar bone is called periodontium, that it composed of different ligaments for the fixation of the root to the alveolar bone. And also the tooth also via the ligaments that are connecting to the gingiva as well, that I'm going to discuss. The crown of the teeth, they have different surfaces. So if we consider the lower jaw and upper jaw, the outer surface is usually called vestibular surface, or sometimes it's called in frontal segment, they call labial, and for the distal segment is called the buccal surface, or generally you can say the vestibular surface. Then the inner surface is called oral surface. If we are discussing for the lower jaw, instead of oral surface, you can say lingual surface, and for upper jaw you can say palatine surface. Then each tooth has approximate surface. Approximate surface, it's the surface that one tooth is connected with the neighborhood tooth. And we have whatever we are going from the midline far toward the posterior side is called the distal direction, and vice versa, whenever we are going from the distal toward the midline is called mesial direction. So this approximate surface, it can be divided to the mesial surface and distal surface. For example, if I consider the first molar in this tooth, so we have here this surface is called the mesial surface, and here is called the distal surface. Then another surface, they are the surface that you are biting. In the molar and premolar teeth, we have the occlusal surface, usually is called, and in frontal teeth that you are biting, it's usually they call the incisive margin or incisive surface in the incisors and canine mainly. So those are the surfaces of the tooth that you have to know, and this is the general terminology. So parodontium is the general terminology for the structure that they are fixing the tooth inside the jaw. Parodontium or parodontium, the correct terminology. It means the parodontium is composed of the gingiva, it's composed of the alveolar bone, is composed of the periosteum of the alveolar bone, it's composed of the ligaments that they are fixing the tooth to the alveolar bone, and also the cement, because those ligaments they are attaching to the cement or cementum that is covering the root and the neck of the tooth. So this is the general terminology which is called parodontium. Then another terminology is called periodontium. Periodontium, those are the ligaments that they are fixing the tooth, or basically the neck of the tooth and the root of the tooth to the alveolar bone and the gingiva. So this periodontium, you have the fissure or the space here that is filled by the ligaments that the basic structure, they are the collagen of Sharpey's structure and Sharpey fiber, and they have, according to their direction, they have different name. This fissure approximately is 0.15 to 0.25 millimeter, and it's divided to two parts. One part is interalveolar part. Interalveolar part, they are composed of three ligaments: the horizontal ligament, the oblique ligament or oblique fiber, and apical or periapical fiber or ligaments. Those are, as you see, the apical or periapical ligaments, the direction is vice versa of the direction of the oblique. Horizontal is the horizontal. Those are the ligaments that they are called interalveolar part. They are attaching or connecting the alveolar process of the jaw to the cement of the tooth. Then we have the supraalveolar part. The supraalveolar part of the periodontium, it's connecting the tooth and mainly the neck of the tooth toward the neighborhood structure. This yellowish ligament is called circular ligament, which is the most common ligament and is connected to the gingiva. And this ligament, the red one, is called transseptal ligament. And this transseptal ligament, it's connecting the neck of the tooth with the neck of the neighborhood another tooth. And finally, we have the ligament of the alveolar process, which is connecting the neck of the tooth to the apex or the upper part of the alveolar process. So those are the ligament of the supraalveolar part of the periodontium, and they are playing role for the fixation of the tooth inside the socket. So during the extraction, you have to detach all these ligaments from the tooth, and then you can do the extraction. The last ligament that is keeping or fixing the teeth in its place is the apical, and by the extraction then you remove the tooth from the socket. This is the difference between the parodontium and periodontium. Okay, so the human being, it has two generations of the teeth. One generation is deciduous teeth or milky teeth or temporary teeth, which are here, and the number, they are altogether 20. It means in each quadrant we have 5 teeth, which is 2 incisors, 1 canine, and 2 molar. So the other quadrant also. So in this case, altogether we have 20 teeth. Another generation is permanent teeth. Permanent teeth, they are the number, they are 32, it means in each quadrant we have 2 incisor, 1 canine, and 2 premolar and 3 molars. So in each quadrant we have 8 teeth, and together is 32. So that's why, because of this 2 generation, we use the terminology the diphyodont or diphyodont. Then the shape of the tooth, they are different, as you see. The shape of the tooth, they are different, and that's why we are using in the human being the terminology of the heterodonts. Heterodonts or heterodont, it means that we have different shape of the teeth. So for example, the frontal teeth is for the rupturing of the food and laceration of the food, and then the other distal teeth is for the grinding of the food are used. So they have the different functions, so that's why, and the different shapes, so that's why we have different function and different shape that is called heterodont. Then in this case that we have for the deciduous tooth, we have 2 incisor, 1 canine, and 2 molar. We don't have premolar, so the digit number that we are using for that is 2102. For the deciduous is 2102. For permanent teeth, that we have 2 incisor, 1 canine, 2 premolar, and 3 molar, we are using 2123. So this is for the permanent teeth. This is another information. Then the difference between the deciduous teeth and permanent teeth, they are, we said already, the number is 20 in deciduous, and permanent is 32. The deciduous teeth, they are smaller than the permanent, they are the color, they are more whitish than the permanent, the deciduous teeth, and also the crown of the tooth, they are much more shorter and smaller than the permanent, but they are copying the shape of the permanent tooth. And finally, the root of the deciduous teeth, they are more diverging to have between the roots there to have the germ of the permanent teeth. This is another information that you have to know. So for the writing the tooth, or we have different type. The most common use that we are the most common form that we are writing about the tooth is the 2-digit system. 2-digit system, it means that we are dividing the face of the patient to the 4 quadrant. The upper right quadrant is the quadrant number 1, the upper left quadrant is quadrant number 2, lower left quadrant is quadrant number 3, and the lower right quadrant is quadrant number 4. And 2-digit system, there are 1, 2, 3, 4. There are the tooths that we mentioned from incisor to the last molar. And for example, if I want to mention the tooth number 4, the first premolar of the permanent teeth, so I am saying for the right side upper, it's tooth number 14. For example, if I want to use the tooth number second molar permanent, it's for the lower left side is 37. For the quadrant for the deciduous teeth, we are using the quadrant as a 5. The upper right side, upper left side is 6, lower left side is 7, and lower right side is 8. So if I want to write the tooth, for example, for the upper canine on the right side, the deciduous teeth, I have to mention tooth number 53. So in this case, this is one way that we are using mostly to determine the tooth, or also you can use the letter the letter, for example, I as a incisor, and C as a canine, P as a premolar, and M as a molar. And if you write it with the capital letter, it means that it's a permanent teeth, and if you write it with the smaller letter, it's the deciduous teeth. And of course, there are different type of the writing of that and determining of the teeth. So regarding the jaw, the upper jaw, the upper dental arch, looks like ellipsoid shape, and the lower dental arch, it looks like a parabola. This is another information. Another information that you have to know about the eruption of the teeth. So as you know, first is erupting the deciduous or milky or temporary teeth, and followed by the permanent teeth. So the first deciduous teeth that is erupting, it's first incisor at the age of the 6 till 8 months, usually the lower one and then the upper one. Then at the age of the 7 till 12 months, it must be erupting the second incisor, first the upper one usually, and then the lower one. Then is erupting between 12 till 16 months the first deciduous molar, usually the lower and then the upper first. Then the canine at the age of the 15 till 20 months, usually the lower first. And finally, at the age of 20 till 24 months, the second molar, the deciduous molar, is erupting, usually upper and molar together, upper and lower jaw, second molar together. So in a healthy person, usually till 2 years of the age, the child must have all the deciduous teeth. Of course, this is variable in the race, in the different place that you are living, and also in the girls and in boys there are difference. Then the first permanent tooth that is erupting is the first molar, that at the age of 6 till 8 years of the child, it's erupting, usually the lower one first and then the upper one. Then the first incisor at the age of 6 till 7 years, and then the second incisor at the age of 7 till 9 years. Then first premolar, then the canine, and the second premolar between the age of 9 till 14. Usually it's erupting these 3 teeth. First premolar, then canine, and the second premolar. Then at the age of 10 till 16, it's erupting the second molar, and finally the wisdom teeth, which is the third molar. It's at the age of 17 till 30 years of age, so it's erupting the wisdom teeth, and sometimes is not. It's possible that not to be erupted. Regarding the occlusal and occlusion, in 80% of the people, the occlusal, it must be that the upper incisor, it must be covering approximately part of the crown of the lower incisor. This type of the occlusion is called the psaliodontia, and in less percent of the population, they have the upper jaw, the incisal edge of the incisor, it's edge to edge with the lower incisor, and in this case they call the labidodontia. And we have the different anomaly and variation that is abnormal, that the central incisor of the upper jaw will be more vestibulary, and it's making a roof for the lower jaw. It's called the stegodontia. Then there is a progeny or progeny of the mandible that instead of the upper teeth, it's covering the lower teeth. The lower teeth, it will be in front of the upper incisor, and in this case we will use the terminology of the progeny. And there is a space between the upper incisor and lower incisor, which is called opisthodontia, and then of course we have this open bite that the teeth, they are not reaching to each other at all. That is called hiatodontia. So those are the information about the eruption of the teeth, the milky or deciduous, and eruption of the permanent, about the shape of the upper dental arch and the lower dental arch, which is ellipsoid and parabola, and the normal occlusal in the human being. So at the region of the oral cavity proper, the main organ that we have it's tongue. Tongue is a very strong muscular organ that it's very movable, and by this moving of the tongue you can push the food toward the palate, toward the tooth, and toward the posterior part for mixing it with the saliva, for the helping it to grinding and biting. And it's by pushing posteriorly or dorsally, it's pressing the food toward the or directing the food toward the oropharynx. The tongue, we have two surfaces at the tongue. We have the dorsum of the tongue that you can see it in this picture, and we have the inferior surface of the tongue. Tongue, usually we divide them to the three main parts: the apex of the tongue, which is located mostly anteriorly, then the body of the tongue or corpus of the tongue, and then it's the root of the tongue, which is here. The difference between the body and the border between the body and the apex, the body is making the anterior 2/3 of the tongue, and apex is making the posterior 1/3 of the tongue. And border between them, there is this V-shaped sulcus, which is called terminal sulcus, which is at the place that this V shape it's meeting each other, and the center is called foramen secum. And foramen secum is the remnant of the embryological structure, which is called thyroglossal duct, because the tongue and the thyroid gland, they are connecting together via this duct. And after the birth and the developmental is finishing, so the remnant of this thyroglossal duct is in this area, which is called foramen secum. So the tongue also is divided to the two parts: the oral part, which is, as a matter of fact, is the part of the tongue which is in front of the terminal sulcus, and the pharyngeal part, which is the root of the tongue, and the part of the tongue behind the pharyngeal, behind the terminal sulcus. Then we have in the side of the tongue, we have the margins of the tongue, and at the center of the tongue you can see the groove or sulcus, which is called median lingual sulcus, which is separating the tongue to the right side and the left side. And if you continue deep, there is a connective tissue which is called lingual septum, which is dividing the tongue to the right and left, not completely, because they are communicating with each other. And also at the dorsum of the tongue, it's under the mucous membrane. There is another dense connective tissue which is called lingual aponeurosis, which is separating the mucosal layer from the muscular layer of the tongue. And this is the place of the two dense connective tissue. One is aponeurosis and the other is the septum of the tongue, which are the muscles of the tongue. They are attaching to that. At the corpus or body of the tongue, in the dorsum of the tongue, you can find at the mucosal layer some papilla. And this papilla, according to their shape, we have different name. The most common and papilla that you can find it wherever on the dorsum of the tongue is called filiform papilla. The filiform papilla, those are the smallest and the narrowest and most common papilla that you can find it in the anterior two-thirds of the tongue, which is the corpus of the tongue or the body of the tongue. Between this filiform papilla, we have another papilla which is a little bit larger, and in macroscopically it looks like reddish points. Then they are locating usually between this filiform papilla and they contain the taste. They are the taste. They call it the caliculi gustatory or gustatory caliculi, and they are responsible for the taste also. So this is called a fungiform papilla. Then we have the foliate papilla. The foliate papilla usually they are located in the margins of the tongue and near to the terminal sulcus here. Those are the foliate papilla, as you see, and also they contain also the taste caliculi. And they are also responsible for the taste. And finally, in front of this V-shaped terminal sulcus, there are approximately 7 till 12 largest papilla that you can see macroscopically also is seen. Is called valate papilla or circumvallate papilla, and those papilla they contain the taste caliculi. And they are the main papilla that they are responsible for the determining of the taste. Just for your information, the tip of the tongue, it's determining or the recognizing the taste for the sweet. Then a little bit posteriorly to the apex and in the side, this is the place for the determining of the salty or salty taste. And in here it's the place posterior to that in the lateral side. It's the place for the perception of the sour taste, and in the back side of the tongue, there is a place for the perception of the bitter food or bitter taste. So those are the papilla that we already mentioned. Is the filiform, filiform papilla, then the fungiform papilla, then we have the foliate papilla and the circumvallate or the vallate papilla that we already mentioned. If you go to the pharyngeal part of the tongue or the root of the tongue, which is behind the terminal sulcus or the sulcus terminalis, we don't have at the root or pharyngeal part, we don't have the papilla. We have the lymphoid tissue, which is called tonsils, and it's here is called the lingual tonsils. Those are the first defense mechanism when you are eating some food which is contained of some bacteria or microbes, so they will be catched in this lymphatic tissue that are located in the posterior 1/3 of the tongue, which is the root of the tongue or pharyngeal part of the tongue, and those are the lingual tonsil. Then behind the tongue is connected to the epiglottis via three-fold. One fold, which is in the midline, is called glossoepiglottic, the median glossoepiglottic fold, and the other, which is paired, is the lateral glossoepiglottic folds, the right and left side. And between these three folds, there is a place which is called vallecula, epiglottic vallecula. These two places, that there is a place that the food, after biting and after is mixturing with the saliva and after the grinding, so they are accumulating here and is ready for the swallowing, and it's going to the pharynx. So that's why then the laryngeal inlet, it will be closed, and the food, it will goes to the pharynx, and then it continue to the esophagus. In the lateral side here, we have another structure which is called palatine tonsil. Palatine tonsil is another lymphatic tissue which is located in the palatine fossa or palatine sinus, which is bordered by the two arch with the same name muscles. The anterior arch is the palatoglossal arch, which is it going toward the root of the tongue, and is making a triangular fold. And the other one, which is posteriorly, is the palatopharyngeal arch, which is also the same as palatopharyngeal muscle. It's posterior border of this palatine tonsil, and superiorly this palatine tonsil is bordered by the semilunar fold here, which is the superior border of the palatine tonsil. So this is the palatine tonsil, this is the lingual tonsil at the root of the tongue, or the pharyngeal part of the tongue, or just posterior 1/3 of the tongue behind the terminal sulcus. Those are these two tonsils. They are the part of the Valdier ring, and those are the ring of the lymphatic tissue that together with the tubal tonsil, which is near to the opening of the eustachian tube at the nasopharynx, and the other is pharyngeal tonsil, which are located in at the nasopharynx. They are making a ring, which is called Valdier ring, and those are participating in the defense mechanism of the body. So the lingual tonsil, palatine tonsil, tubal tonsil, and pharyngeal tonsil, that it was in the part of the respiratory system. Okay, so this is the inferior surface of the tongue. So if you put your tongue upward and you look at the inferior surface of the tongue, you will see, for your orientation, here is the apex of the tongue, and here is the lower teeth, and here is the upper teeth. So at the inferior surface of the tongue, in the midline, you can see this structure which is called frenulum, lingual frenulum. Lingual frenulum is connecting the inferior surface of the tongue to the floor of the mouth. This is one connection. For your information, we have another frenulum that we have it in superior lip and the inferior lip. This is called labial frenulum. Don't do mistake with the lingual frenulum. This labial frenulum, they are connecting the upper lip and the inferior or the lower lip to the vestibular part of the gingiva. So here at the midline is the lingual frenulum. Then you can see some folds that they call fimbriate fold or pellica fimbriata. Those are the remnant, embryological remnant of the sublingual mucosa that you can see it in the human being as a fold that is called fimbriate fold. Then parallel with this fimbriate fold, you can see the bluish color structure, which is the vein that is passing in this region and is called the deep lingual vein. And in some literature also you can see the sublingual vein. It's correct also, it's seen, and it's very well seen if you look at it in the mirror. You can see the bluish color, and this is the vein that it passed. So this frenulum that we said that it goes to the floor of the mouth at this region, suddenly in the midline there is a structure which is called sublingual caruncle. Sublingual caruncle, it's the place that the submandibular duct and the major this is the submandibular duct, and the major sublingual duct is open to this region, and it's located at the both side of the frenulum, the lingual frenulum in this region. So the sublingual caruncle is the place for opening of submandibular duct plus major sublingual duct. Then if you go it from this caruncle in the distal side and in distal side here, in the both side, you see that there is a fold which is called sublingual fold. And at this sublingual fold there are some orifice, and is the place that the minor sublingual ducts, they are open to the sublingual fold. So be careful once more. At the floor of the mouth you see the sublingual caruncle is the place for opening of submandibular duct and major sublingual duct, and also the sublingual fold, which is the place for the opening of the several minor sublingual ducts. Those are the structure that you can see in the floor of the inferior surface of the tongue. Immediately below the apex of the tongue, there is a gland, the salivary gland, which is called lingual apical gland, salivary gland, or anterior lingual gland, which is immediately below the apex of the tongue is located. And the secretion is the seromucinose secretion. It means that is a mixed secretion, and it's passing parallel with this fimbriate fold and above of the fimbriate fold. For your information, this is the one of the largest minor salivary glands that is located below the apex of the tongue. And another glands that we have it inside the tongue in the dorsal part, in the other side, and usually in the root of the tongue is located, is one gland which is the serous gland, and is located near to the, around the circumvallate papilla. Is called Ebner's gland, and it's open around the surface of the circumvallate papilla. And the other, which is the which has a mucinose secretion, and it's located at the root of the tongue, in the pharyngeal part of the tongue and root of the tongue, and it's called Weber's gland, and it's a mucinose gland, and it's helping for the mixing with the foods, and is helping for the lubrication of the food, and in this case the swallowing, it will be better. So these three glands, the Ebner glands, which is the serous gland, the Weber glands, which is the mucinose gland, and the anterior here in the inferior surface, the anterior lingual gland, or the apical lingual gland. This is the seromucinose, is the mixed gland, which is here is C. Muscles of the tongue. As we mentioned, the tongue is very muscular organ, strong organ, muscular organ, and in this case the muscles of the tongue is very important. As I mentioned before, this green part that you can see it on the surface of the dorsum of the tongue is located and is separating the mucous layer from the muscular layer. This is and is oriented horizontally is the aponeurosis of the tongue, is the dense connective tissue, and the other dense connective tissue that you can find in the tongue, and it's passing sagittally in the midline of the tongue, is called the septum of the tongue or the lingual septum. So these two dense connective tissue, they are the place for attachment of the muscles. Muscles of the tongue, we divide them to two groups, the intrinsic and extrinsic, or it can also be said the intraglussal and extraglussal muscles. Intrinsic or intraglussal muscles that you can see it here, the name is come because the origin and insertion of these muscles, they are inside the tongue. It means that they are originated from the tongue and they are inserted inside the tongue. And according to the direction of the fibers that they are perpendicular to each other, the name is arising. So the intrinsic or intraglussal muscles of the tongue, for example, here the red line, they are the vertical muscles. The vertical muscles, they are making the tongue more flat. Then you have this orange fiber that they are passing transversally. They call transverse muscle or transversus muscles. That they are narrowing of they are making the tongue narrow. And finally, those color, the brown color here, they are called longitudinal. They are passing in this frontal section is cutted. So they are the longitudinal muscle, and longitudinal muscle usually we divide them to the superior and inferior longitudinal muscle, or sometimes they call it superficial and deep longitudinal muscle. These longitudinal muscles, they are shortening the length of the tongue. Generally, in this case, the intraglussal muscles, they are changing the shape of the tongue. It means that longitudinal, they are shortening. The transverse, as you see the transverse, they are also in some part penetrating the lingual septum. The transverse, they are narrowing the tongue, and the vertical, they are flattening the tongue. They are changing the shape of the tongue. All these intraglussal muscles, they are innervated by the cranial nerve number 12, hypoglussal nerve. Another group of the muscle are extraglussal muscles or extrinsic muscles of the tongue. Extraglussal or extrinsic, they are called because they are originated from the tongue. It means usually from the aponeurosis or lingual septum, and they are inserted outside of the tongue to the neighborhood structure, the bony structure that they are near to the tongue. And according to them, this we have three types or four types of the muscle. The muscle, which is the most important muscle or the most bulky muscle and the largest muscle of the tongue, is this muscle, which is called genioglossus muscle. As we mentioned it in the skull, is originated from the superior mental spine in the inner surface of the body of the mandible, and is inserted to the aponeurosis of the tongue. The function is protruding the tongue. When you are protruding the tongue outside of your mouth, it means that they are pulling the tongue toward anteriorly and inferiorly. So it means that protruding the tongue. This is very important for the examination of the hypoglussal nerve, cranial nerve number 12. I'm going to discuss. Next muscle of extraglussal is originated from the greater horn of the hyoid bone and the body of the hyoid bone here that you can see, and here is the cut edge of this muscle is called hyoglossus. Hyoglossus is originated from the greater horn and body of the hyoid bone and is inserted to the lingual aponeurosis to the side of the usually the root of the tongue. The function of this muscle that is pulling the tongue toward the downward and posteriorly. So it's pulling the tongue downward and posteriorly, when it's contracting bilaterally. If it is contracting unilaterally, or it means in one side action, the tongue it's pulled toward its own side. Then another muscle that is originated from the styloid process of the temporal bone is this muscle and is inserted toward the margin of the tongue is a styloglossus muscle. Styloglossus muscle, it's this muscle originated the styloid process, insertion to the margin of the tongue, this muscle, this is the muscle, and here, and this muscle, it has a function that is pulling the tongue toward the upward and posteriorly, and of course in unilateral action it's pulling the tongue toward its own side. These three muscles, they are the three pure muscles of the extraglussal muscles of the tongue, and all of them, they are innervated by the cranial nerve number 12, hypoglossal nerve. You can see in different literature another information or another name of the muscle, which is called palatoglossal muscle. The palatoglossal muscle is this muscle that it's cutted. We already mentioned it as a palatoglossal arch, which is making the anterior border of the tonsillar fossa, the place that the palatine tonsil is located. The anterior border, it's the palatoglossal arch and under that is palatoglossal muscle. This palatoglossal muscle, in some literature also, they are considered as muscles of the tongue, but in other literature, mainly it's the muscles of the palate, the soft palate, that we are going to discuss it. And that's why, because of this, we have the different innervation for this muscle, which is innervated usually by the cranial nerve number 9, the glossopharyngeal nerve. The so the extraglussal or extrinsic muscles of the tongue, they are moving the tongue as a whole. Intraglussal or intrinsic, they are changing the shape of the tongue. And all of them, they are innervated by cranial nerve number 12, hypoglossal nerve, except the palatoglossal muscle, if we consider it as a muscles of the tongue. It's innervated by cranial nerve number 9, glossopharyngeal nerve. Here is the region of the tonsillar region. It means that the region that the palatine tonsil is located. The palatine tonsil is the lymphatic organ that it's located in the fossa, which is called tonsillar fossa, or sometimes they call it tonsillar sinus here. As we mentioned it before, is anteriorly or ventrally is bordered by the palatoglossal arch or muscle, and dorsally is bordered by the palatopharyngeal arch or muscle. Superiorly, there is above the tonsillar fossa, there is a fossa which is called supratonsillar fossa, and above that there is a fold which is called semilunar or semilunar fold or pellica semilunaris. Here, that is superiorly is bordering the palatine tonsil. The place that the palatoglossal muscle is attaching to the root of the tongue, we already mentioned that it can be a muscle of the tongue, or it can be muscles of the soft palate. Here there is a fold which is called triangular fold. Laterally, this muscle is attaching to the muscle of the pharynx, which is mainly the superior constrictor pharyngeal muscle. Laterally is attaching, and laterally is covered by the dense connective tissue, which is called tonsillar capsule. And between this tonsillar capsule and the wall of the pharynx in this region, there is a paratonsillar vein and vessels. And during to the tonsillectomy, it means removing of the tonsil, there is a danger for the cutting of these veins and the vessels, and the bleeding, it can be sometimes fatal. Then the important thing is that in the medial surface of the tonsil, it's not covered by the capsule, and you can see even in the mirror, if you look at your tonsil, you can see the small depression which is called fossula tonsillaris, or the tonsillar fossulae. And this tonsillar fossulae, those are the small depression or fossa that deeply they are continue as a crypt. It means the tonsillar crypt, and in this surface sometimes they are accumulating, in the case of the infection, they are accumulating the pus and exudation, and by pressing of the tonsil you can see that the pus or exudation is coming from the tonsil. The lymphatic tissue or lymphatic drainage of the palatine tonsil, it's going to the deep cervical lymph node, and it's one of the this tonsillar palatine tonsil is one of this Waldier ring for the lymphoepithelial ring, which is together with the tonsillar, lingual tonsil, tubal tonsil, and pharyngeal tonsil. They are making this Waldier ring or Waldier lymphoepithelial ring. This is once more in this picture. You can see the red one is the palatoglossal. The yellowish part behind it's the palatopharyngeal, the anterior border and the posterior border. Here is the tonsillar fossa or sinus. Superiorly, here is the uvula, and this one is the tensor belli palatini muscle. Here above this region, as we mentioned it, here is the supratonsillar fossa, and above that is the semilunar fold. So here all about the palatine tonsil. Regarding the innervation of the tongue, which is very, very important, and we are going to discuss in the nervous system again. But the innervation of the tongue, we classified it as three groups. The motoric innervation that we already mentioned, there are the somatomotoric innervation, that they are innervating the muscles of the tongue, and it's innervated by the cranial nerve number 12, hypoglossal nerve, except the palatoglossal, if it is considered as a muscles of the tongue, it's innervated by the glossopharyngeal nerve. Then we have sensitive innervation. It means that, for example, you have experience if you eat some hot food, you feel hot, or if it is ice cream, you feel cold, or for example, if you have some sharp structure inside the food and you feel pain. So those are the sensitive innervation. The sensitive innervation of the tongue for the anterior 2/3 of the tongue, which is the body of the tongue, it's innervated by the lingual nerve, which is branch of the mandibular nerve, which is the third branch of the trigeminal nerve. The sensitive innervation for the posterior one-third of the tongue, which is the root of the tongue, it's by the cranial nerve number 9, which is the glossopharyngeal nerve. And the sensitive innervation of the tongue in the area of the glossoepiglottic fold and the vallecula epiglottica or epiglottic vallecula, it means the connection of the root of the tongue with the epiglottis, it's by the cranial nerve number 10, which is the vagus nerve. This is the sensitive or general sensation of the tongue. Then the third classification is the sensory innervation of the tongue, which is responsible for the taste fiber. For the taste fiber innervation or sensory innervation, for the posterior one-third and the region of the glossoepiglottic fold is the same as the sensitive or the general sensitive innervation. It means that the posterior one-third of the tongue, which is the root of the tongue, is innervated by the glossopharyngeal nerve, and the region of the epiglottic and glossoepiglottic fold and epiglottic vallecula is innervated by the vagus. But what is important, the taste innervation or sensory innervation for the anterior two-thirds of the tongue is the cranial nerve number 7, which is facial nerve, which is giving a branch which is called chorda tympani. Chorda tympani we already discussed, that is arising from the descending part of the facial canal, and it's passing through the petrotympanic fissure, and it's then is joining to the lingual nerve, and it's carrying the taste fiber and parasympathetic fiber to the lingual nerve. So the taste fiber or the sensory innervation for anterior two-thirds of the tongue is by chorda tympani, which is branch of the facial nerve. So this is the difference between the sensitive and sensory. It means that the general sensation and taste fiber innervation of the tongue. Regarding the lymphatic drainage of the tongue, which is very important for the carcinoma of the tongue, the most important, from the apex or tip of the tongue, the lymphatic drainage, it goes to the submental lymph nodes. From the margins of the tongue, it means that the lateral margins of the tongue, the drainage, the lymphatic drainage, it goes to the submandibular lymph nodes. From the central part of the body of the tongue, the lymph node, they are draining to the nodes, one of the lymph nodes or the group of the lymph node that they are belongs to the deep cervical lymph node and is called jugulo-omohyoid lymph node or Kocher lymph node. This is called jugulo-omohyoid lymph node because it's the place that the omohyoid muscle is crossing the internal jugular vein. So this is the either you can say the deep cervical lymph node. If you want to talk about the specific lymph node, it's called jugulo-omohyoid lymph node or Kocher lymph node. It's taking the lymphatic drainage from the central part of the body of the tongue. Then the lymphatic drainage from the posterior one-third of the tongue and the isthmus faucium and sometimes the tonsils, the lingual tonsils, they are draining to this lymph node, which is also belong to the deep cervical lymph node, and it has a specific name which is called jugulo-digastric lymph node or Kittner lymph node, and it's taking receiving the lymphatic drainage from the posterior one-third of the tongue. Immediately above the Kittner or the jugulo-digastric lymph node, it's the tonsillar lymph node or Wudo lymph node, that it's the place for the taking or receiving the lymphatic drainage from the palatine tonsils. This is very important for the tongue, the lymphatic drainage of the tongue. and you have to know that the lymphatic drainage from left side and right side of the lung, tongue, it can communicate to each other. So don't be surprised if some person has carcinoma on the right side of the tongue. The lymphatic enlargement, it can appear also in the left side also. So here is macroscopical anatomy of the tongue. Here you have the tongue, the human tongue. As we mentioned it before in theory, the tongue, it has several parts. The first part is apex, lingual apex. Then there is anterior two-thirds, which is called the corpus or body, and posterior one-third, which is here, and it's called the root of the tongue. And the border between the corpus and the root is the groove, which is here, is called terminal sulcus, is a V-shaped groove. And to find this terminal groove or sulcus terminalis, you can find immediately in front of them there are the largest papilla at the dorsum of the tongue, which is called the circumvallate or vallate papilla. So here it's the terminal groove or sulcus terminalis, and here at the region of the apex of this V shape of the sulcus is the foramen secum, which is the remnant of the thyroglossal duct. Here there are the margins of the tongue. Usually the cancer is happening in the inferolateral surface of the tongue, here in the margin of the tongue. And as we mentioned it, here is the dorsum of the tongue, and here is the inferior surface of the tongue. Here is other tongue that you can see it also. Again, I mentioned it. This is apex, this is margins, this is body. Those are the circumvallate, so it means that here is the terminal groove or sulcus, and here is the foramen secum, and here is the root of the tongue. Here is the dorsum, and here is the inferior surface of the tongue. As you see, the tongue, at the surface of the tongue, it's the lamina mucosa or mucus that it's covered by the epitel. Epithelium is the squamous epitel. And on the surface of this epitel, you can see several papilla. This, I don't know if it will be catched here. This small papilla that you can see is everywhere in the body of the tongue. It's the filiform, or sometimes they call it conical. Filiform is the better terminology. Conical is for the animals, is used usually. Filiform papilla, and wherever around the dorsum of the body of the tongue it's seen. Then there are the larger, which is in the fresh specimen or in a live person, that if you look at it, they are the small point of the reddish color, and it's called fungiform, and usually is anterior and lateral surface of the tongue. Between the filiform they are located the fungiform papilla. Then on the margin of the tongue and posteriorly here, there are another papilla which is called foliate papilla, the foliate papilla here. And finally, the macroscopically is very well seen here. It's like a V shape in front of the sulcus terminalis or terminal groove. You have the vallate or circumvallate papilla. This fungiform, foliate, and circumvallate, mainly the circumvallate, they contain the taste caliculi, and they are responsible for the perception of the taste fiber. At the root of the tongue, which is the posterior 1/3 of the tongue, is it will be considered this bigger structure. They are not papilla. At the root of the tongue, we don't have papilla, but we have the lymphatic tissue, which are called lingual tonsils. And they are immediately behind the terminal groove is located. This root of the tongue posteriorly, it's connected with the epiglottis. This is the epiglottic. This via the fold, which are called here, it's the median glossoepiglottic fold. And in the both sides, there are the lateral glossoepiglottic fold, the right side and the left side. And between them, between these three folds, it's the fossa, which is called vallecula. It's epiglottic vallecula. As I mentioned, it's the food is accumulating here and is ready for the swallowing. And during the swallowing, you can see the larynx, it go up and epiglottis goes down, and it's the inlet or laryngeal inlet, it will be closed, entrance to the larynx, and the food it's going to the pharynx, the pharyngeal space. In the both side, you can see here the palatine tonsils that it's bordered anteriorly by the palatoglossal arch or muscle, and posteriorly by the palatopharyngeal arch or muscle. And here is the another lymphatic tissue. Maybe here is much more better seen the region of the root of the tongue. Here is the terminal sulcus, and those are the circumvallate papilla. These bigger points that you can see, those are the fungiform, and the all other smallest and narrowest one is the filiform. And here in the margin of the tongue and posteriorly, you can see here is the foliate papilla. Then at the dorsum, here there are the lingual tonsils, and it's very thin. Here is the connection of the root of the tongue to the epiglottis as a glossoepiglottic fold, the median one. And here is the lateral, the right lateral and the left lateral glossoepiglottic fold. And between them, those are these two vallecula epiglottic, vallecula or vallecula epiglottica. It's here. And laterally was the palatine tonsil. So the inferior surface of the tongue, if we look at it, as we mentioned it, under the apex of the tongue, in this area, there is a apical salivary gland or lingual salivary gland, or sometimes it's called anterior lingual salivary gland. Is the seromucinose gland for the secretion, and is one of the biggest minor salivary gland. Then here in this area there are the fimbriate fold. This is the embryological remnant, and here in this region there is a sublingual vein or deep lingual vein, and here is the place of the frenulum of the tongue, which is connecting with the floor of the mouth. Regarding the upper border of the oral cavity, which is formed by the palate, we divide them to the hard palate and soft palate. The hard palate, we already mentioned it in the skull section, that the bones that they are making the hard palate, they are from anterior to the posterior is peremaxilla or incisive bone. Then the palatine process of the maxilla, that they are together making the anterior 2/3 of the hard palate, and then behind that the posterior 1/3 is made by the horizontal plate of the palatine bone. So those are the bony structure that they are making the hard palate. At the hard palate, it's covered by the mucous membrane that it contains the palatine glands, that they are minor salivary glands, and also in most of the part of the hard palate we don't have the submucosal connective tissue. It means that the mucous membrane it's firmly attached to the periosteum, and in this case they are making the mucoperiostal junction. So the exceptional place for the mucoperiostal junction is exactly approximately behind the central incisor. There is an incisive papilla that under that is incisive canal, that the nasopalatine nerve, and the vessels they are passing, and here, and also the place that the greater palatine nerve and artery they are passing in the palatine groove. We have some small submucosal connective tissue, and that's why these two regions they are used for the application of the local anesthesia. So here you are looking at the oral cavity proper. Here again for your information that we mentioned, here is the oral vestibules. Here is superior frenulum, or the frenulum of the superior lip or upper lip, and frenulum of the lower lip. And here is the oral vestibules. And after the dental arch and alveolar process, inside is the oral cavity proper that we already discussed about the tongue. And here in the hard palate that is covered by the mucoperiosteum, in the center, in the midline, you can see a rough, is whitish structure which is called palatine raphe, and this palatine raphe is separating the right side from the left side of the palate. So that's why the inflammation, it cannot spread from right side to the left side of the palate, because of the firmly attached the mucus to the periosteum in this region. As we mentioned it here behind the central incisor, and here the passage of the greater palatine vessels and nerve, the palatine papilla and palatine sulcus, they are the place that the submucosal connective tissue is existing, and in this case we can apply the local anesthesia. On the surface of the mucous membrane of the palatine, you can see a fold, a few folds that it's called the transverse palatine fold, and around this area in the dorsal region mainly you can find the palatine glands that they are belongs to the minor salivary gland. After the hard palate, we reach to the region of the soft palate. In the center you can see the ovula, which is hanging in the midline. Be careful, it consists of two muscles, it's a paired muscles, but you can see as one unpaired structure in the midline. And here you can see the tonsillar fossa or sinus, which is bordered by the palatoglossal and palatopharyngeal arch or muscles that we already mentioned. Here you can see the soft palate. The soft palate, as a matter of fact, is the posterior one-third, is forming the posterior one-third of the palate. It means that it's the dorsal continuation of the hard palate. The soft palate is passing or is directed horizontally, and at the end it's going downward at the place of the ovula in the center. The basic structure of the soft palate is a dense connective tissue which is called palatine aponeurosis. Palatine aponeurosis is the place that all the muscles of the, or most of the muscles of the soft palate, they are attaching to that, and it's making the basic structure of the soft palate. It's very important, the muscles of the soft palate, that there are 5 muscles belonging to the soft palate. The first one is this green color muscle, which is originated from the spine of the sphenoid bone, or angular spine is called, or also is originated from the lateral surface of the cartilaginous and membranosus part of the eustachian tube or auditory tube. It's going downward and medially, and the tendon is turning around the pterygoid humulus. If you remember in the skull, at the end of the medial pterygoid plate, you can see the hook-shaped structure which is called pterygoid humulus. The tendon of the tensor veli palatine is turning, and it goes medially and is inserted to the aponeurosis of the palatine aponeurosis or aponeurosis of the soft palate. The function of this muscle is, according to its name, tensor veli palatini. It's tensing the soft palate. Also, there is another function to the eustachian tube or auditory tube, that between the literature there are different information, but the most of the case they are writing that the tensor veli palatini is called also the dilator of the tuba. Dilator of the tuba, it means that is open the opening of the eustachian tube or pharyngeal tube, because it's attaching to the lateral surface of the cartilaginous and membranosus part of the eustachian tube, and in this case by contraction it open it. In other literature also they call it vice versa, that it's tensing, and in this case they are narrowing and closing the opening of the eustachian tube. The innervation of this muscle is exceptionally and is innervated by the mandibular nerve, which is the third branch of the trigeminal nerve. Then the next muscle that you can see as a bluish color, it's the levator veli palatini. The levator veli palatini, which is located more medially to the tensor veli palatini, and is originated from the apex of the petrosal part of the temporal bone and inferior surface of the petrosal part of the temporal bone, and also is originated from the medial or internal wall of the eustachian tube, and is inserted to the palatine aponeurosis. According to its name, which is levator veli palatini, it's elevating the soft palate, mainly during the swallowing and also during the phonation. So again, for this muscle also in some literature they call it as a constrictor muscles of the tuba, and in this case they are writing that is closing the orifice of the eustachian tube, but other literature they are saying that vice versa, it's is opening the orifice of the auditory tube or eustachian tube. This levator veli palatini is innervated by pharyngeal plexus, which is mainly formed by the cranial nerve number 9 and 10, glossopharyngeal and vagus. You can see in some literature only glossopharyngeus. It take or it receives some fiber from the facial nerve during the phonation. So during the phonation, it's taking some fiber from the facial nerve. Next muscle that you can see, and as I mentioned, is paired muscle, is ovule, musculus ovule or ovular muscle, is originated from the posterior nasal spine and is continue as hanging on the center of the posterior part of the oral cavity at the beginning of the isthmus faucium, and the function is during the swallowing or phonation. By the contraction of this muscle, it's closing the nasopharynx. So by the contraction, it's closing the entrance to the nasopharynx. That's why the food it doesn't go to the nasal cavity or the nasal part of the pharynx. And finally, there are these two muscles that I already mentioned. The red one is the palatoglossal muscle, that it's making the anterior border of the palatine tonsil, and is originated from the aponeurosis, palatine aponeurosis, and is inserted to the the margin of the root of the tongue. Beside that, it's making a triangular fold, or pellica triangularis, and posteriorly and the function is the narrowing of the isthmus faucium, and the other one, the posteriorly, is the palatopharyngeal muscle, which is again originated from the palatine aponeurosis and is inserted to the lateral wall of the pharynx, and also the function is by the contraction they are narrowing the isthmus of faucium. Both muscles, they are innervated by pharyngeal plexus, which is formed by the cranial nerve number 9 and 10, glossopharyngeal and vagus nerve. So those are all the muscles of the soft palate that are important. So this is a posterior view toward the pharynx. Why I choose this preparation to show you another extrinsic or extraglussal muscle of the tongue, which is this muscle, is originated from the styloid process here and is inserted to the lateral part of the tongue here, and is called styloglossus muscle. For your orientation, here is the mastoid notch, and in this case here is the posterior belly of the digastric muscle, that if I continue here, it will be continue with the anterior belly of the digastric muscle here, and this is the intermediate tendon. And here it's the styloid process of the temporal bone, and this muscle that it's penetrated by the tendon of the digastric muscle is the stylohyoid muscle, as you see, is attaching to the hyoid bone, and then it's the styloglossus muscle, which is here, and the most medial part, it's the stylopharyngeal muscle, is one of the muscles of the pharynx that we are going to discuss about this. And all these muscles, they are making the styloid septum, which is dividing the parapharyngeal space to the prestyloid and retrostyloid space of the parapharyngeal space. And here, for your orientation, here is the internal jugular vein. Here is the internal carotid artery, and posteriorly between them it passed the vagus nerve. This is the content of the carotid sheath here, and again this muscle is the sternocleidomastoid muscle, and any nerve that it goes to this muscle is the accessory nerve, which is the cranial nerve number 11. So this is the thing that I wanted to show you here. If you look at it from the chin or the mental region or submental region, you can see the anterior belly of digastric, and if I remove the anterior belly of digastric, immediately I will reach to this muscle, which is called mylohyoid muscle, and this is the border between the neck region, which is here, and if you go above, you will reach to the sublingual region, which is the region inside the oral cavity and floor of the oral cavity. And since here is the hyoid bone, so in this area it's passing the muscle which is called hyoglossus muscle, as another extrinsic muscles of the muscle of the tongue. And this is all about this preparation. Dear students, that's all about the first part of the gastrointestinal tract. Thank you for your attention. In next videos, we are going to record another video about the salivary gland and pharynx, esophagus, stomach as a second part of the gastrointestinal tract. Thank you for your attention, and I would like to thank my colleague for his help to record this video. And thank you for your attention. Stay safe, study hard.